Good afternoon, everyone. This is Tom Merrill with the ACLC, and you are joining the committee report webinar for our Q4 cohort, or the committees that met through the winter of last year, starting in October in our DC in-person meeting and wrapping up in December. We have 3 committees that will be reporting out today, so this is going to be very action-packed, very punchy, and we have just 3 really great representatives from those committees who we'll announce here in a minute. But specifically, we'll be reporting out from the Committee on Stakeholder Engagement, the Committee on Financial Collaboration, and the Committee on SDOH Integration, SDOH being Social Determinants of Health. And we're excited to share with you a brief overview of what the committees concluded in their time meeting together last year. So real briefly, for folks on the phone who are not as familiar with the ACLC, I'll give you a very brief explanation of what the ACLC is. It is a collaborative organization that, as you can see on your screen, we're made to bring stakeholders together. Organizations within healthcare that are leading the way on moving us to a value-based system. And as you can see, there's a lot of different folks involved. Most of the members are, however, representatives from provider organizations. So physician groups, hospitals, health systems, and everyone in between. But we do like to get different viewpoints. Oftentimes we'll have payers on these committees representing that perspective and a variety of others. The ACLC is housed at a nonprofit university. It's Western Governors University. You'll see that name from time to time, but they are our host. And in 3 phrases, the objective of the ACLC is to help providers who are leading this transition know what they should do, when they should do it, and how they implement it. One of our the graphics we tend to share the most is our landmark resource that we published a couple years back, and it's what we call the Accountable Care Atlas. And it is the first time any crazy organization decided to try and put every value-based care competency that was being asked of providers in this era on one document, and that's what you see in front of you. So the idea being there's a lot of things that are being asked of provider organizations in terms of responding to value-based payment. There's 160 on here, and it's a lot, and you can't even read the text, but the idea is that it's supposed to give you some sense of the breadth of the work that lays ahead for most organizations, and this is supposed to be somewhat of a guide. The point of these committees, which I'll dive into more in a second, is to take one of these competencies at a time, bring leaders from across the nation to deliberate on what is required, what are some of the challenges, what are some of the insights they can share from their experience, and share that with the nation. So the 3 folks that you're about to be introduced to have been very generous with their time and their experience. All are from organizations that are just really on the bleeding edge of this, learning a lot, making mistakes, but also seeing successes, and we're excited to have them share with you the point of view from their end, from the front lines, if you will. Briefly, the way the committee process works is that we, through a combination of ACLC members, and oftentimes we go outside of the membership to find folks who are leading on this particular topic. We will go and ask them to be a part of this committee. We'll interview them in pre-session interviews. That's the block you see here on the left. We'll have a first meeting to kind of orient everyone, a second meeting that just jumps right in, and then for this particular committee, I actually think it was virtual, so it was kind of reverse. Meeting number 1 was in person, meeting number 2 was virtual, and meeting number 3 was also virtual, where we work through the issues and produce some of the publications that we'll be announcing today. At the bottom of the screen, you can see some of the topics that we've done most recently in the various cohorts. So today, as you can see, that second from the left, Q4 committees, we'll be talking about the Committee on SDOH Integration, Stakeholder Engagement, and Financial Collaboration. We have kicked off in 2020 2 additional committees, one on data aggregation, one on medication optimization. And if you would like to observe those, please reach out to myself or Bree or Sergio. Our information will be at the end of this slide, and we will get you connected into those. We'd love you to be a part of those learning opportunities. And so those committees are underway. Q2 committees, which will kick off in March in Chicago, I guess it's already March, excuse me, March 24th and 25th in Chicago, are on high-value partnerships and home-based care. And those committees are coming together very nicely, some really impressive organizations and people with great experience and a willingness to share, and we'd love to plug you into those as well. So please let us know. We'd love to count you in our journey. So let's jump in to the Committee on Stakeholder Engagement. As I mentioned, this group met from October to December of last year. A really impressive group of panelists, as you can see here, from across the nation, a pretty diverse group as well in terms of provider configurations. And then our sponsors. So 3M, we want to give them 3M and the American College of Cardiology a special shout out because they underwrite these committees to make them so that we can have guest participants and observers that don't they get to participate at no cost, and so it allows us to broaden our audience to organizations that may not have the financial ability to join these collaboratives fully and spread the lessons that we are gathering in this work. So you can see some of the names there on the left. I won't go through them, but I will call out Christine Perez from the American College of Cardiology and Han Pak from 3M, both huge contributors, and we're grateful for their sponsorship. To preview what will be in the publications that I'll talk about on the next slide, this group did the very hard task of breaking down what stakeholder engagement looks like, sort of parsed out. We know that stakeholder engagement is a big effort. It can mean a lot of things, and so this committee did the hard part, and they broke it down, and you can see sort of the 3 main components that they came up with. I'm not going to read those. Those will be in what is called the Competency Orientation Guide, which let me jump to that. On the left here, you have just a screenshot of a generic competency orientation guide. But the way that this document is structured and its intended purpose is to be a 2-page, so very high level, summary of the committee's deliberations for those 3 to 4 months. And it just really forces us to distill to just the very essence of what these leaders are discussing and the insights they're sharing. And so you can see some of the structure, the background for a given competency. I'm sorry, that's the background for the ACLC, but the approach and important terms, things that are important for an executive to kind of get their head around before they really start diving into full-fledged programs that obviously would require more than this 2-page document. But at the end of this 2-page document, the Competency Orientation Guide, it does point to deeper resources, recognizing that if an organization does want to go down this path after reading this doc and getting that overview, they know where to go. They know where to go next, even if that is a handoff to a manager for actually making this thing happen. On the right, we have sort of the pair publication that will come out of this committee, and that's what we call a case study brief. And it's what it sounds like. It's a brief case study, also limited to 2 pages. In this particular situation, we profiled the University of Iowa. This is Laura Cullen, who is a fabulous member of the committee. At University of Iowa Healthcare, they have a long tradition of engaging stakeholders, and so we went to them and said, now how has this changed under value-based care? So we did our best to capture that and put that in a 2-page case study. It obviously could have been 10 pages, but this will give you a brief view of what it looks like at one particular organization. So very practical. Both these documents taken together. I won't explain them again for the next committees, but for those who are new, that is the structure of these publications, and we hope that they will be useful to you as you contemplate the various competencies that your organization is developing. So without any further ado, let me introduce the representative from this committee, Brian Vamstad of Allina Health, a name that we're all very familiar with, a very early entrant into value-based care, one of the earliest ACOs, and Brian, I know from the committee staff, was a huge contributor to this committee, and we are so lucky to have him give us the committee report. And let me just preview real quickly that I'm going to ask each of the committee representatives 3 questions, and I'll show them on the slide, so even if you miss the question, you can see what they're responding to. But I'll have Brian introduce himself, and then I'll hit him with the hard questions. So Brian, are you there? And please introduce yourself.
And thank you, Tom. I appreciate it. Again, my name is Brian Vamstad with Allina Health, Manager of Regulatory Affairs and Payment Policy. And Allina Health, we are a integrated not-for-profit health system. We're based in Minneapolis, Minnesota. We have 11 hospitals that spans the metro area along with rural areas and also into western Wisconsin. Over 90 clinics and 29,000 plus employees. So we're a very large integrated healthcare delivery system and really kind of centered in a very competitive market that's really changing the way that care is delivered. And before I came to Allina, it was just about 9 months ago, I spent 11 years at Gunderson Health System out of La Crosse, Wisconsin. So I'm very happy to be pleased and part of this committee and to contribute, and look forward to the discussion.
Thank you, Brian. Okay, first question for Brian is, as I mentioned in the outset, Brian, this is a broad topic, yet you guys with your committee staff, Greg Kotzbauer, Kevin Evans, were able to make this a bit more tangible. But can you tell us what stakeholder engagement looks at Allina?
So one of the things that struck me in relation to the work that we did with the stakeholder engagement, and I'm actually referring back to the very first set of notes that we had from the October meeting. And I think this one is really fundamentally important to stakeholder engagement. And one that we're seeing really being articulated right now is the communication about the why. Why are we going in this direction towards value-based care? And this is fundamentally important because it needs to be supported, bought in, communicated all the way from the board level through the executive leader team, all the way down to the system level leaders. That is really the fundamental starting point about identifying what that is, and then you can really build it out across there. What it also does is it helps align the system to the goals and strategies. So you have the why, it's just a broad piece, a broad message, and then you're able to fill that in with the system goals and strategies. And we're really starting to really see that come alive here, and I'll talk a little bit more about the reasons for that, but we're really supporting that through a number of initiatives. So you have that broad, so as my thought process is broad to narrow, you start very broad with the message, you start filling that in with your goals and strategies to be able to execute those, and then underneath it is the actual operations to fulfill those goals and to meet those, what you had put forth. So I think a lot of the things we're doing about moving towards value-based care, such as being a participant in the Accountable Health Communities model through CMS, that really helps show that we are committed to that. We are engaging with leaders, we're engaging with staff, and really sharing that message of here is why we need to go into this direction, and also making sure that that is spread as far and wide as possible, that everyone has a part into this journey. And the one example that I can provide that I think this really was heightened over the last 12 months was this fee-for-service and value dichotomy that's going on right now. And I know a lot of organizations are really sitting in that tough spot right now. This last year in 2019 was really a major impactful year for our system, and probably many others as well, where over the past many years since we've been doing this, you have this fee-for-service environment, and from a financial perspective, really it was kind of a lot of the same. You could do a little things here and there, but overall, to maintain your margin, you would be forced to rely on tests and procedures as volume-based care. But this last year, what started off was just kind of small ripples, turned into white caps, and then came together as a tidal wave. We had all kinds of changes from payers. We had a drop in inpatient services. Reimbursement was falling way short, and ultimately, we had a very tough year financially. So I know that a chief financial officer would cringe to hear this, but in some senses, when you have a very difficult year, that underscores the message about why you need to transform. Now, of course, we don't like dealing with a tough financial year. Nobody does. But what it did do is that it really demonstrated that, look, healthcare is changing. It is moving in this direction, and if we don't adapt, we are going to be in major trouble. However, that said, even though we had a tough financial year, we did come out with a very small positive margin. But what we did is we encompassed that into a broader message of this is what we did in the communities. This is what we're doing to support this journey, knowing that you're kind of between a rock and a hard place right now. But everything has come together to say, hey, we need to move on this fast. I would say, being in this work for about 12 years now, that we could see this coming. And I don't think, though, we were quite ready for it to hit as fast as it did. So the whole cascading of the message from top all the way through the organization, far and wide, and being able to align with that, I think is fundamentally important to stakeholder engagement at a broad system level.
Well, thank you, Brian. Those sound like some very difficult but crucial conversations, especially at this juncture, and it sounds like they were sorely needed. So appreciate the insight from your organization on that. My next question is maybe bring it back to Alina has a rich history in this. You have a lot of experience. But the whole point of the committee sometimes is to bring those diverse perspectives, people from other markets. What is one of the greatest takeaways that you took from the actual committee discussions?
Well, I have three of them. The first one you hit the nail on the head, was just about the different perspectives. And when I was preparing my notes and reading from our past notes on this, that is what I really appreciated. We not only had different perspectives from different types of organizations, from payers, universities, integrated health systems, independent physician groups, et cetera, but we also had different thought processes within each individual member. I don't know if anybody's ever taken the colors test before about what your thought preferences are, whether you're blue, green, red, or yellow, et cetera. But I felt like we had all those colors represented, everything from broad visionary thinkers to operational execution, process thought orientation people in the committee. And I believe that makes it a lot of fun, because you can really get a lot of broad feedback that plays into each other. You're able to bolster a much broader, bigger narrative. That's definitely the first one that I really appreciated. The second one was when you get our final competency guide, the piece that I really gravitate towards most, and I encourage everybody to read, is we, as part of each of these categories of stakeholder engagement, looked at what are the biggest challenges we face, but then what did we do about them? You identify the problem, but then we have some tips in there about how to solve them. And I think that from a practice standpoint, you can utilize that as a guide to help you when you're facing those challenging situations. What is a message, or what is a way to go about doing that? And sometimes just those quick tips are very, very helpful. Which leads to my last point about I really enjoyed the discussion about how we prioritize or map stakeholders. How do we tier them? And that was part of our first notes that I remember going back through and reading about. How did we do this? How did we identify those that had the broadest influence? Those that maybe have a high level of expertise on there. Do they have reasons to engage with you? What's their credibility? Do you have aligned values? Those sorts of things help play into how you tier your stakeholders. And the last kind of sub-point in the visualizing stakeholders was about don't align just with yes people. I have found that even in smaller projects, not just about the journey to value, that if you have a small group of people that are very honest with you, are very credible, but they may be in that sort of maybe slightly skeptical department, that appreciate everything they have to say, especially some of the naysayers. You never know, because if you work out of it and you hear them, they may identify some very important elements to what you're going to or trying to work towards, you may be able to bring them into the yes category as one of your big champions. So that's one of the practice tips that I have as a small sort of kitchen cabinet, if you will, that they'll be very honest with me. I appreciate their feedback, and it's sort of a good way to keep you grounded and keep you honest.
That's great. Thank you, Brian. It sounds like the structure of the committee was such that, you know, those differing viewpoints prepared you for the very act of engaging stakeholders and maybe even dealing with the skeptics. So thank you. All right, last question is, what does this look like going forward? So stakeholder engagement has been, I'm sure, an important aspect of your work from the beginning. What does it look like in the next phase?
Well, the next phase here with as a system and as we look into 2020 and beyond is executing the plans. Like a lot of systems are facing a lot of challenges and changes right now, and we are no different from that. So there's going to be continuous changes over the next, you know, months and years, and the way that healthcare is being delivered in our communities is also going to change because of many reasons of moving towards value, but how the interplay of private payers and all that coming together is really going to be changing how healthcare looks. So that continuously communicating the why and then aligning it across the system and executing the plan, and ultimately taking some risk. I mean, there's going to be some risk out there, both financially and human resources and everything above about moving in this new space, and you got to be, you know, ready for it. But the stakeholder engagement is going to be very critical internally and externally. And I'd say over the past year, there's been a lot of very strong internal focus about the message and the why. What we will see, and this is kind of where the department I'm with really comes into play even more so, is that external side. You know, we have a great community benefit and engagement team. One of my, you know, coworkers here, she was on the Social Determinants of Health Committee. You know, always out there in the communities, but we're going to be really broadening that message to wider audiences externally, from lawmakers, the general public, our patients we serve. Everybody has to understand the why, maybe a little bit differently, but they need to understand that the way that healthcare has been delivered throughout our communities, throughout our system, is going to look a lot different moving forward. So being able to articulate that will help your external stakeholders really understand and respond and be able to, you really know where you're coming from, and they're not caught off guard, or you're not dealing with some potential you know, negative issues. So I think moving forward, we're going to see a bit more of a shift, especially in the external realm with those stakeholders moving forward. They've always been engaged, but I think that's going to really heighten, especially over the next several months and next few years as we move into this journey.
Yeah, Brian, and I'm sure the work that you've done internally for years will make that external work just so much more effective by having everyone internally on the same page. So, well, great. Well, good luck with that. And again, thank you for the committee report, and we're so lucky to have had you. So thank you for your time, Brian.
Thank you.
Okay, so let us move on to the next committee, and this intro will be a lot briefer. The Committee on Financial Collaboration also met in October, kicking off in our DC in-person meeting and wrapping up in December virtually. Also, just a really impressive group that you can see there on the left, quite diverse, also with some universities, health systems, but additionally, you know, folks like Jennifer Nolte of the National Association of Community Health Centers. Such a diverse group, and the same, we want to call out our sponsors, which made it possible for us to involve such a diverse group. Sam Wallner and Julie Spalding from Lumeris. I know Sam really came in toward the last couple meetings of the committee and represented Lumeris well and made a huge contribution. Julian Whitekiss, who is a veteran of the ACLC and a very long-time sponsor, always a substantive contributor. Thank you to Julian and Hanover. And then Jessica Kratz-Merck, similar, have been with us a while, very patient as we are all learning together, and just huge contributors. So take a look at that group on the left, and most of these folks you guys will have met. Reach out to them if you need to go deeper into some of these things. So The preview for the competency framework, we're talking about what it's like to when you're collaborating with partners, which is almost the inevitability of value-based care, where you're sort of figuring out how you as an organization can handle population health, and then you realize you're going to need external partners. What does it look like when you actually need to create financial relationships? So this committee took the first stab at this topic, also an ambiguous topic, but they did fantastic, broke it down into these three elements, which you can see on your screen. I won't read it for you, but you can go deeper. The competency orientation guide, I think, is about to be published. We will send that out through the newsletter. It's something I didn't mention earlier. We'll send it out through the newsletter for our members. For those who are not members and don't get that newsletter, get on our list so we can send you that newsletter. I think we can send you a version that at least has these publications, and we'll tweet out links to the orientation guide for this. So follow us on social media. For this particular case study brief, we profiled the physician organization of Michigan ACO. The representative, if I go back here, this was Tim Peterson. Also, we had Tariska, both contributors. So very much looking forward to that being published. And we'll give you great sense for what this looks like on the front lines. So let me stop talking as soon as possible and turn it over to Phil Smeltzer, who is our committee representative. Phil was a huge contributor on this committee, and he hails from South Carolina. He's the Population Health Program Administrator at the Medical University of South Carolina. And Phil, I will let you introduce yourself before I get you with questions.
Thanks, Tom. So I have been personally on the healthcare plan side for most of my career since the mid-90s. I've been here on a delivery system side for the last 6 years. So I, just so you know, sort of a bias or the perspective that I brought to the committee. But as Tom said, it was a nice, diverse group. And I think just the discussions on the committee were insightful in the way they occurred, because sometimes, you know, somebody from a health plan side would make comments, and then somebody from the provider side on the committee would have to sort of provide perspective that there's a different way to look at whatever the topic was, and vice versa, which I think really spoke to the matter of how this collaboration can occur and some best practices, or more like, here, let me show you this scar. And this, you want to avoid this. So that's sort of where I come from, and some of the observations on the committee.
Well, thank you, Phil. And it's probably appropriate that we have that healthy tension in the committee, because that tension definitely exists in the market. And I think, to your point, really informed a broader perspective on what this competency looks like from all angles. So, but let's go to your point of view, specifically your organization. What does financial collaboration look like at MUSC?
So we have about 70% of our primary care patients are in some type of value-based agreement. Our largest is with CMS, where we have just a little bit over 20,000 beneficiaries. Our footprint is primarily an academic medical center. We have 4 hospitals in the urban core. We have about 24 locations of ambulatory sites. And then we have a regional hospital network that has 4 facilities that are community-based. And so between the community-based addition, which is within the last year, just about a year anniversary, and with a growing portfolio of agreements, there's a lot of diversity in what our collaboration looks like. So with CMS, as I think everybody knows, you know, you decide whether you want to do this or not, and there's not a lot of negotiation. But I think the counter to that is, obviously CMS is a very mature organization from their deliverables. And they've got their networks and the learning, et cetera. Now, if it doesn't necessarily function at the efficiency level we would like it to, I think, at all times, but but it's a good model and it works. At the other end, we had talked to an organization, a health plan for 3 years, and they still haven't not been able to provide us good, clean data, but we're going to sign a contract with them because we're not going to accept downside risk. And it's mostly an incentive, and they're taking some money off the table, moving it around. And so we're able to accommodate each other that way. So it was a very, very good. The two organizations get along with each other quite well. We've got a long history, but we weren't going to sign downside until we saw good, clean data files. In the middle, there are some of the more, there are the larger commercial insurers, and we've found them to have varying levels of ability to be flexible on agreements, negotiate. Not, I think everybody negotiates in good faith, or at least they try to, but they don't have either flexibility on terms, or they don't have flexibility in data, or they don't understand our needs. And I think that was the collaboration theme, was both parties have to understand the needs of the other and really get some full disclosure. Why are you doing this? You know, for the health plan to ask the provider, so why do you want to go at risk? I mean, why would you want to go from fee for service to risk? Because it's a fad? Because your board wants to do it, or what do you think's in it for you? And vice versa. You know, the providers, why are you having this discussion? Obviously, it's to shift cost and risk, but really, why do you want to do business with us? And that helps clear the air, and the committee members related that sometimes some of those elephants in the room trip people up before they're revealed. And sometimes they're never revealed, they just become understood.
Yeah. Well, Phil, your comments are reminding me of the internal struggle we actually had here within the ACLC initially when this committee came together, and that was we had initially envisioned that this committee would focus on collaboration between provider partners. What quickly emerged from the group, and it's great, this is organic, we like the committees to self-guide and talk about what is most relevant to them, was that these conversations were much more payer-centric than we had anticipated, which I think actually gets at the stage of development that the industry is in. Most of these contracts, whether with CMS, as you said, that are just kind of take it or leave it, or with private insurers, which are maybe a little bit more flexible, most of that collaboration is taking place between system and payer, and maybe next order is when there's deeper collaboration between provider entities. We actually, maybe this is more of a shout out to a forthcoming committee, and that is we think the next phase of this committee will be more provider centric. So for anyone who thought that that was what we might be covering exclusively, surprise, this is how the committees work, and we really love what came out. So Phil, with that, I'll come back to you. Let's bring it back to the topic, and that is specifically the discussions, how they went. What was the greatest takeaway that you took from the committee's deliberations?
I think the greatest takeaway was in the spirit of collaboration to make sure that everybody, that both sides or all sides, because you know in a CIN, you know, you may have multiple stakeholders, parties, that everybody understood what the decision-making process and the governance process was. That several folks related that the parties at the table had an agreement, so the some organizations thought they had an agreement, and then, oh well, yeah, but it has to be approved by our board, and that was never mentioned prior to that point. And the delay in the decision-making process was one, but it really gave, you know, all parties pause that, oh my God, I mean, not that we weren't dealing with somebody of authority, but not the ultimate authority, or we just didn't understand what was occurring. That theme to a lesser degree occurred in other areas. The data and the availability of data, and understanding what the other party either needs or is capable of providing, and why, if you can't provide it, what are the limitations and why? Is it, your system just can't do it? Or is it that you don't have the resources to make the system deliver the data? And also, on the other side, if you're catching the data, why do you need that? Understand why you may want it, but why do you need it? And having those robust discussions that really it all got to a theme that overrode all committee interactions and discussions and dialogue, and that was, it was transparency. That was the word. It was all about transparency. In order to build a collaborative, everybody needed to know the various angles, needs, strengths, weaknesses, and if this was going to work, you really had to put all your cards on the table. The better that occurred, the better the discussions. And it seemed that when those cards were put on the table earlier, there were some opportunities for individuals to say, well, I don't want this, I don't want this, this is a problem. And those were cleared up early, and they weren't contentious points. They were clarification issues, or, oh, I understand where you're coming from. There, okay. And then it was able to be accommodated over time. So the earlier that transparency and the degree of the transparency occurs, the better. So that was definitely the takeaway. Transparency and making sure you understand the governance process so that ultimately it's all going to come down to an agreement. How are those agreements and those deliverables to be consummated? If you want me to keep talking, I'm not going to do it.
Yeah.
Oh, I was on mute. I was totally on mute. Thank you. You just take it. We got 20 minutes left, Phil. You just keep going. Now, I was saying to a room, an empty room, that I could ask a bunch of follow-up questions, but I'm going to point to the orientation guide that I had the pleasure of editing. There's plenty in here about that. So if people want to go deeper on what I agree was one of the main themes, please see the orientation guide. Lots of great insights. Okay, so last question, because we want to make sure that we have Kendall's full time, because we want to hear from Kendall. What does financial collaboration look like going forward, Phil, at your organization?
So we don't have too many more primary care patients that we can put in a value-based contract. So one strategy is to convert our upside-only agreements to two-way risk, and maybe even greater risk with bigger corridors or full capitation in some select populations. I don't know if we'd ever do that for 20 or 30,000 members. So expanding that. The other is kind of to what the original focus of the committee. We're a little bit unique. So we're an academic medical center. So out of 800, well, now it's out of 1,000 physicians, we only have maybe 5 that are not full-time paid physicians in the urban core. In our regional health network, it's somewhat of a hybrid, but still it's dominated by staff physicians. So we're really a staff model. Not everybody here appreciates what that means and how the advantage is. We're not taking advantage of that, but that's what we have. And we have a physician group. We have the hospital entity, and then we have a university, classic, typical, if not universal, AMC type of model. So we're trying to figure out how to move the money around and create incentives, because we're, in essence, a not-for-profit, technically a state institution, but we're an authority. But we don't have we don't have capital. It's tough to go get capital for this type of funding. So we're trying to figure out how to provide incentives and increase the collaboration and the compensation plan. It's, one would expect, the practitioners are completely focused on RVUs. So in this market, the state, there's virtually no managed care, and there's very little awareness or experience at large in the front lines with managing risk and being exposed financially. So we we have a lot of ground to cover on that spectrum and that evolution. And so that's what financial collaboration looks like for us. With the payers, it's growing risk. With the providers, it's shifting risk to their shoulders and compensating them when they perform well.
Gotcha. Well, thank you, Phil. That actually is a nice little segue into incentive alignment, which was a committee that met in Q3. And for those of you who joined us on our last report webinar, that was one of the 2 committees that reported out. Their orientation guide is up on the website along with their case study brief, which profiled the work Memorial Hermann did internally to kind of align these, compensation packages, et cetera. So great. Thank you, Phil. Really appreciate your insights, and we'll be eager to see how things go for you in this next chapter. All right. Well, without any further ado, let us go to Kendall. So the Committee on SDOH Integration. The other committees, very hard stuff. I almost want to say that SDOH integration is the hardest one for a variety of reasons. One, this is about obviously expanding the scope of what the healthcare system is traditionally known to oversee clinically. The committee, with huge contribution from Kendall, did their best to put their arms around this. I'm going to breeze through this because I'd rather hear from Kendall. Fantastic group of panelists that you can see, but Accenture and the National Association of Community Health Centers, very appreciative of their sponsorship of this committee, especially given the nature of the topic. Yes, this is bleeding edge. Yes, this is top of mind for everyone, but it was a hard one. And Michael Peterson of Accenture and Michelle Proser both just brought invaluable experience from the work that they're both doing in very different angles or different aspects of the industry, but really came together to produce some rich resources. Obviously, the framework, which I'll just preview here, and also give a shout out that you can see that elements 3 and 4 that the committee identified as being very, very important, they actually weren't even able to get to. They left it for a part 2 committee. So look for that. It might be this fall, maybe in the spring of 2021, but we definitely think that there was enough here to revisit the resources that have been produced focused on 1 and 2, measuring and tracking SDOH impact, and then engaging external health system and community-based partnerships. So some overlap with the Stakeholder Engagement Committee. The case study brief for this was Allina Health, which we heard from Brian earlier. His organization was also generous enough to be the subject for this case study brief. It's fantastic. The orientation guide also, I think, is probably already up on the website now. So please go check those out. But let me turn it over to Kendall Craig, Senior Director out of Renown Institutes, one of the few organizations that are involved in the ACLC from out here out west. So Renown, very prominent organization in Nevada. So Kendall, are you there?
I'm here.
Okay, give us a brief introduction, and then I want to pose you the same questions.
Sure. Well, thank you for the introduction. Renown Health, probably most of you have not heard of it. We are a not-for-profit, and we're the only not-for-profit health system in Northern Nevada. We operate 2 hospitals, have a joint venture for a 3rd, and then, as you can imagine, a large bit of our business is also in the rural communities. So that's an intro. I am the director of the institutes, and that's basically part of the population health organization.
Okay, well, thank you, Kendall. And I get to see Renown's billboards every time I drive to Tahoe from Salt Lake City. So,
yeah,
so
that's where I live, actually.
What a great area. Okay, I probably should have known that, but that makes a lot of sense. Well, great. Well, thank you, Kendall. SDOH, as I mentioned in the intro, this is a tough topic, and you guys were willing to venture out onto the foggy edge of the industry's understanding here. But at this stage of industry's development, what does it look like at Renown?
So, Renown is, I think, taking a little bit of a leadership role here. Our CEO comes from a public health background. He's also a pediatrician. So he comes to this with thinking to the future, right? Thinking about value and how do we get there. So the Renown Institutes, which I lead, are part of the population health organization, and we focus on 3 populations: behavioral health and addiction, children, and aging population. In addition, we're kind of around 3 different pillars: health equity, healthcare transformation, how do we make this transition to value, and then value itself actually resides in the Institute. So I lead the ACO. And our work is around what you'd expect, traditional social determinants and social behavioral issues, but we're also willing to venture into kind of the unknown. So an example of that is we were just awarded the Build Health Challenge grant from Robert Wood Johnson Foundation, and we're doing work around social isolation and loneliness in our elder population. We have a very high rate of elder suicide, and we're 51st in the nation in mental health services in Nevada. So really our focus is on trying to solve problems. We don't do innovation for innovation's sake, but we try to look at what are the things that our population is struggling with and how can we jump in and help with that. That work?
I'm on mute again. I'm sorry.
It's okay.
I was just going to say, Kendall, we know that this kind of work is hard, and then you put it in a rural setting, and I'm sure it gets even harder. So I'm glad to hear that you guys are leading out on that. Coming back to the discussions, a pretty diverse group. I'm sure there were organizations in pretty different situations than Renown, but what were some of the things that you took away from the committee?
Well, first of all, I would say it was a very diverse group, and everybody's experience, I think, was different. And I think what you could map that to was where were they in their value journey. Some of the folks were, first generation ACOs, and they were way further along than some of us who weren't. So that was interesting. I think I had 3 takeaways I wanted to mention. One was a business case is essential. So the journey to value has to be part of it. Otherwise, this work doesn't make a whole lot of sense. Yeah. Secondly, this is new work, and it's often uncomfortable. And I think it kind of goes to the first topic, right? If this isn't something that's embraced by your whole organization, it's very hard to get alignment and get people excited about this type of work because their day-to-day doesn't relate to this work. And I'm not going to say that's solved at Renown. I still fight that battle. Pieces of our business are still fee for service. And this only makes sense if you're thinking about from a value perspective and you're investing in that and realizing that this work isn't quick. It takes a long time. You're not going to see an ROI in a year. It's going to take a couple years. I think the challenge also that I heard from everybody is where does it start and stop? It's new. Are you an anchor institution? Are you leading? Are you just part of a committee? And thirdly, I just add that it's hard to get the credibility when you do go outside your organization or sometimes even inside your organization. Why are we doing this? This seems very far away from what I do day to day in my service line. Or when you're out in the community, they're thinking, okay, what's the hospital doing here? They've never been part of these discussions before. Do they really care? And so I feel like we're constantly kind of selling ourselves and trying to prove ourselves internally and externally. And again, going back to that business case, how can we demonstrate that this work actually pays off?
Which I think, Kendall, is going to be one of the focus areas for the next time that this committee reconvenes, whether it's this fall or next spring, and that is demonstrating ROI. Incredibly hard. Demonstrating ROI on value-based care in general, and that's the service lines that we are familiar with partners that we are used to working with. This just adds a layer of complexity to that.
Yep. Agreed.
Okay, well, very important insights. Thank you, Kendall. Let's talk about what this ongoing work will look like for Renown. The next phase.
Yeah, besides business case and data and proving ourselves and all that good stuff, I guess the only other thing I would add to that is just starting to broaden our thoughts about social determinants and which of our patients are struggling. I think all of us think that it's our Medicaid population, you know, that's the low-hanging fruit. I think we'd be surprised at how many of our Medicare fee-for-service and even our Medicare Advantage patients are struggling. We just started a personal assistant program in our call center where our Medicare Advantage patients, which we operate a Medicare Advantage product, have somebody they can speak with. And it's amazing how many of the seniors they talk to are food insecure, need transportation, and basically are lonely and need a friend. So I think that it's easy for us to box it and kind of, you know, stereotype this work. And I think we will be surprised that if we start to broaden the reach, that we will have even more impact.
So it's possible that in a year, Kendall, we could be talking about this, and what SDOH integration meant in 2020 is something completely different in 2021 as you're learning and getting out into the community in a different kind of way.
Yeah. Yeah. And I think it's all new, right? You're going to have to prove it and see what comes out. So I think another thing someone said, I actually wrote down this quote, was, you know, they use their Medicaid population as a laboratory, right, for innovation. They can test things there because there's no wrong, there's no wrong way to go. And I think that's kind of the spirit of it. We've got to test this stuff. We got to pilot it and see what sticks, what works, and, you know, try again.
And Kendall, does the community seem to be, you mentioned that sometimes they're sort of surprised that the hospital isn't usually present for these kinds of conversations or in these meetings. Do they seem to be receptive, and how hard has that work been communicating your new presence?
I think the proof's in the pudding. You know, with the Build initiative, which is the loneliness, I took the lead, put it together, wrote the proposal. They saw me as their champion. I think I gained credibility over time. And just the other day, I was at a meeting and they said, you know, recreation fees are going to double in Reno, and the city of Reno, there's a city council meeting. Will you come and speak? And the fact that I did, and I spoke on their behalf, on the way out, they're all high-fiving me, and I'm becoming part of their community, and I'm gaining their trust and their credibility. And that's huge. That's huge.
Yeah, it just sounds like the human element.
Yeah.
Well, great. Well, thank you, Kendall. Really appreciate your insights on this committee, and for everyone who that Kendall's remarks has piqued your interest. The competency orientation guide, I think it's up on the website today, and I think the case study brief will also be up shortly, and we'll send those out through all of our channels so you can go deeper. Obviously, 2 pages on both the orientation guides and 2 pages on the case study briefs. It's not a lot, but we build it for you so that if you want to go deeper, you can. So Kendall, thank you for your time and your contribution.
You're welcome.
So I did a horrible job at the beginning of this webinar to signal that we wanted to have Q&A. I think most of you know how to use that module, but we've been checking the Q&A, and I don't think we have any questions. So let me pause and make sure that that's still the case. Bree, Sergio, any questions in the queue?
Not that I can see so far.
Okay. Well, maybe everyone's reading the COGs and the CSBs already, and that's perfectly fine with me. I know in conclusion, let me first state a few things that are upcoming. So I mentioned at the beginning that the next cohort of committees is already underway, data aggregation and medication optimization. If you're hearing about those for the first time, one, we're sorry because they've kicked off, but it is not too late to observe those committees and really get a lot of benefit from getting the last 2 meetings. They will be wrapping up in Chicago on March 24th. And so we, for those of you who aren't familiar with ACLC, we co-locate that meeting with ACHE since we have so much overlap in the leadership. So we try and help you out there with the travel. That will be on the 24th. We can share those details and we can get you in as an observer. the next two committees kicking off that same day, or sorry, the same event, will be on the 25th, and that will be the Committee on High Value Partnerships and the Committee on Home-Based Care, which I have the privilege of being the facilitator on, and those groups are turning out to be really fantastic. I'm excited to see what we produce. If those committees are of interest, please reach out to us. We'll get you involved at the very least as an observer, and we'd love to have you with us in our collaborative learning journey. So one more huge thanks to Brian, Phil, and Kendall for giving so freely of their time, and especially today, and for everyone else for joining us. And go read those resources. We want your feedback and help us improve them and make them even better. So thanks, everybody, and we'll say goodbye for now until our next connecting point. Take care.
Thanks, Time. Bye, everybody.
Thank you.